Vamos a recibir al doctor Melih, que nos visita desde Turquía. Su charla también va a ser en inglés, pero también tenemos traducción simultánea. El doctor es cirujano plástico, cirujano estético, especialista en medicina regenerativa y nos va a hablar de la nueva era de las terapias celulares en cirugía plástica y reconstructiva. Recibimos al doctor.
Thank you. Buenas tardes. Yes. I'm gonna try to talk as slowly as I can. Sorry for the presenter. Sorry for the translator. And hello, everybody. I'm a plastic surgeon for 11 years, and I'm also a stem cell specialist for more than 5 years. I'm using stem cells in my practice for more than 5 years. And it's my first time in Lima, Peru, by the way. It's my first time, and I really enjoy the city. And you have really beautiful views, because yesterday I walked a lot near the beach, near the seaside. Okay, you're done.
The mic, please.
Do you have your pointer?
Yeah, I have. Thank you. Okay. So I'm from Istanbul, Turkey. This is my clinic, and we have lots of branches in our clinic. I'm a plastic surgeon. We have an orthopedic surgeon. We have a dental surgeon in our clinic. And all we have to do in common, we are all using regenerative medicine for our daily practice. So everybody knows stem cells are the principal cells, and they are capable of converting to other cell types. And they can able to renew themselves, to produce more stem cells, and they can able to form tissues and organs. And we can able to use the full potential of stem cells by using point-of-care systems, which I'm gonna describe right now. Point-of-care systems is a type of healthcare systems, and we deliver the products or services at the time of the care. So with the help of these systems, we can able to isolate and prepare the cells at the same place where we're gonna do the stem cell application. So in the previous years, so we have to take the stem cells and just send them to a lab, wait for 10 days, 15 days in order to gain much more cells before we injecting them to the patients. And with the help of the systems, there is no need to send the samples to the lab, so they are freshly isolated. These systems helps us because they decrease in cost. And in previous years, the stem cell application cost much more, but with the help of these systems, it's much more cheaper right now. And also we can able to do the application much more fastly, in half an hour, 40 minutes, and they are highly effective. So we can able to just harvest a real good quality of stem cells. I'm going to tell you the definition of regenerative medicine. It is the science that allows the treatment of injured tissues with biological products. It deals with replacing, engineering, or regenerating human or animal cells and organs to restore and establish normal body function. So there is a term called cellular therapy, which is some kind of organ transplantation, because if we replace these diseased cells with a healthy cell, it is called cellular therapy. It is just like an organ transplant, just like a kidney transplant, just like a liver transplant, because we are giving the body healthy cells just to replace the damaged cells. So which type of stem cell can we use? There is 5 kinds of stem cell. I'm not gonna go into too deep about each of them, but I'm gonna tell the 2 of them more detailed. Embryonic stem cells, I'm going to tell you later. This is the only controversial type of kind of stem cell, which we are not using in our daily practice. Adult stem cells, which present in the tissues of live adults. So we are using adult stem cells in our daily practice, in our stem cell applications. So every adult has a stem cell in present their bone marrow, adipose tissue, dental pulp, and peripheral blood, and every part of the body. Also, we have the 3rd type. We have induced pluripotent stem cells, and which Yamanaka won a Nobel Prize about it, because he found it in 2012. They are adult stem cells, but they have the potential of embryonic stem cells. Also, we have perinatal stem cells. They're obtained from perinatal tissues, such as umbilical cord blood, placental tissue, and amnion. Also, we have cancer stem cells, which they play a role on tumor formation. So this is totipotent stem cells. They both form embryo and placenta, so they can able to produce both placenta and embryo. This is pluripotent stem cells. They can able to form only embryo. If we take this healthy pluripotent stem cells and we isolate them in a culture, we can able to harvest embryonic stem cells. But if you are going to do that, you have to kill the embryo. So that's why there is some real ethical issues about producing embryonic stem cells. So what we can use in our daily practice, multipotent stem cells. They are all present in healthy adult tissue. We have hematopoietic stem cells, we have neural stem cells, and we have mesenchymal stem cells. We can use them, there is no ethical issue about them, and we can harvest them in human body. So what is embryonic stem cells? They have a huge potential in the field of tissue engineering and regenerative medicine. And they can differentiate into all tissues and all types of cells in human body. So they can able to form an embryo, so they can convert all type of cells. But there are some drawbacks about using them, because you have to, as I mentioned before, you have to kill an embryo in order to just create them. And also, they have some potential tumorigenicity problems. And they have some problems with immunological compatibility. So we cannot able to use them in our daily practice. And by the way, President Bush just banned their research, but President Obama in United States just allowed them to just only for the research purposes in USA. And just because of that, they have a limited use in only in drug development, toxicology testing, and disease reversal, such as just like that. And adult cells. This is the type of adult cell that we can only use in stem cell practice, in our daily practice. We have 3 types of adult stem cell. We have hematopoietic stem cell, which forms blood cells. We have neural stem cells, which forms cells of the nervous system. And we also have mesenchymal or stromal cells, which forms connective tissue, bones, and cartilages. But they are not able to form just only connective tissue, bones and cartilages. They can able to transform to other types of tissues, all stem cells. I'm going to tell this detail later, okay? So I'm going to tell a little bit about hematopoietic stem cells. And hematopoietic stem cells, they can be isolated from bone marrow, peripheral blood, and cord blood. And this is the first type of stem cell that's used in stem cell therapy and leukemia patients in blood disorders. You know that, myeloid leukemia patients. And all lineage of blood cells are produced by a rare population of multipotent hematopoietic stem cells. They can able to form all types of hematopoietic stem cells. But they cannot only form blood cells. They can able to transform into liver hepatic progenitor cells. So they can able to just help us for just a little bit liver regeneration also. So they have other capabilities. Also, we have neural stem cells, and we can use them on spinal cord injury, neurodegenerative diseases, and also stroke. They can able to transform the cells of the central nervous system or peripheral nervous system. And it is the first stem cell isolated from a solid organ, by the way. And that because of we harvest them from a nervous tissue, from a neural tissue, we cannot use them in our daily practice because we have to cut the nerve tissue, and this makes a harm to human body. And because of that, that limits their use today. But of course, we can use stem cells in neural degenerative diseases also. We can use mesenchymal stem cells because they can able to transform just like neural stem cells, they can able to transform to neural stem cells also. So I'm going to tell you a definition about stem cell plasticity. This is a term that I mentioned before. Neural stem cells just, they not only, neural stem cells are, give rise to three main types of nervous system. Hematopoietic stem cells converts to all kinds of hematopoietic system cells, but under certain microenvironmental conditions, they can able to generate other cell types besides of their tissue of origin. So hematopoietic stem cells, for instance, for example, they can able to not only form blood cells, they can able to transform into liver cells. So neural stem cells, they not only give rise to nerve cells, but they can able to give rise to hematopoietic stem cells. So this term is called stem cell plasticity. Because of this term, because of this thing, we can able to use mesenchymal stem cells in our daily practice for therapeutic purposes. You see, mesenchymal stem cells has the most stem cell plasticity potential. So we can able to use mesenchymal stem cells in our daily practice, in our therapeutic applications. So because they can able to transform any type of cell in human body, and we can able to use them because it's relatively easy to harvest them in comparison with hematopoietic stem cells, in comparison with neural stem cells. So this is the main stem cell type we use in our daily practice. And it's found on 1960s by Friedenstein and colleagues. And at first they thought they were some kind of stromal cells. They didn't think that it's a stem cell. And then after that, when they found out they can release some prostaglandin E2, which plays a major role in self-renewal ability. Now they understand these cells are really important. They have the capability to differentiate into various lineage of cells, including adipocytes, ectodermal neurocytes, and endodermal lineage. So they can able to transform all types of cells. They have the maximum potential. So why we love mesenchymal stem cells? Because their stemness potency, they are strong cells. We can able to isolate them from different sources. and they can be rapidly expanded on laboratory conditions. We can able to just produce them much more easily than the others. And they have less ethical issues compared with embryonic stem cells. And they transport a lower risk of teratoma formation, which is a major thing on embryonic stem cells. And they are beneficial for wide scale of therapeutic applications. We can easily harvest them, we can easily use them in just half an hour, 40 minutes. So in our clinic. So it's really great for us. So where we can harvest them? There are a lots of region in our human body. So this 4 is the easiest one, but I mostly harvest them from bone marrow and adipocyte tissue because these are the easiest one to harvest. In bone marrow mesenchymal, in bone marrow concentrate, there are lots of cells, but only small amount of is mesenchymal stem cells. And there is only one mesenchymal stromal cell for every 250,000 cells. But there is only one hematopoietic stem cell for every 10 or 15,000 cells. So, and the mesenchymal stem cell concentration in bone marrow is much more less than hematopoietic stem cell. And mesenchymal stem cell ratio decreases with age, but hematopoietic stem cell concentration doesn't decrease with age in bone marrow. So mesenchymal stem cells makes up very small fraction in our bone marrow. And adipose tissue mesenchymal stem cells, they have similar differentiation potential with mesenchymal to other types of mesenchymal stem cell, and they have higher efficiency upon isolation and higher proliferative rate compared with bone marrow mesenchymal stem cells. And they are not multipotent progenitors, not only for adipocytes, they can able to transform all types of cells in human body. And so where to use which mesenchymal stem cells? There is a term called colony forming unit, so with what we call CFU. It is a test that we can able to measure the number of colonies that the stem cell makes. It shows the quality, stem cell strength and quality. There are multiple studies comparing with bone marrow mesenchymal stem cell and adipose mesenchymal stem cells. But there is not a certain literature about which one is better, because in the past there is a literature, bone marrow mesenchymal stem cells has SVU capacity higher than the adipose tissue, and there is another study, no, adipose-derived mesenchymal stem cells has higher SFU capacity than the bone marrow, but the last, in the last literature, they say, no, they have similar capacity, so they are similar. So we didn't know yet. We're gonna learn in the future maybe. But for bone marrow, there is, as I told you before, there is less cells in comparison with adipose-derived stem cells, but bone marrow mesenchymal stem cells have stronger migration capacity. This means there is less bone marrow mesenchymal stem cells are required to achieve a therapeutic effect. That's why we are using them on one therapy. If we gonna use them on one therapy, they are dose dependent. If we gonna do much more sessions on bone marrow mesenchymal stem cells, we're gonna get much more better results. And also, for adipose tissue, if the patient has diabetes mellitus, all you know, diabetes mellitus is decreases the quality of fat in human body. So, and if there is if it's uncontrolled and if the patient has a high blood sugar, we should choose the bone marrow because the quality decreases with diabetes mellitus. And if the patient has a less body fat percentage, you should choose bone marrow too, because you will be struggle to take harvest fat from that patient. Also, there are some factors, but they are all dependent on patient. And they have a lot in common, but there are some little differences. So adipose-derived stem cells are more genetically and morphologically stable on long-term culture. They show a higher proliferative capacity. They retain differentiation potential for longer period in the culture compared with bone marrow stem cells. And also, adipose-derived stem cells support hematopoiesis and in vivo and in vitro. And they do this more efficiently than bone marrow mesenchymal stem cells. And the use of bone marrow mesenchymal stem cell in plastic surgery is less common because I mostly use adipose-derived stem cells because I can able to harvest fat in my every surgery, so it's much more easier for me. And if bone marrow mesenchymal stem cells are beneficial in plastic surgery, only on one therapy. If you're gonna do much more dose bone marrow mesenchymal stem cell to a patient, you will see better results. I'm gonna show my results later. So what is SVF? SVF, stromal vascular fraction, is a component of lipoaspirate which we took from after adipose tissue liposuction. And it was discovered at 2001 by Zook et al. And during processing with collagenase enzyme, which you will see tomorrow in the day on practice. And Zook et al. Found a large number of cells and includes erythrocytes, leukocytes, immune cells, endothelial cells, and also some stem cell precursors, which is adipose-derived stem cells, mesenchymal and endothelial progenitor cells. And they called it SVF. It's a cell cloud. It contains endothelial progenitor cells and adipose-derived stem cells. Endothelial progenitor cells helps for improving vascular function in SVF. So they have a different function than the adipose-derived stem cells. It also increases the vascularization a lot. So what is SVF helps us? How SVF helps us? It increases angiogenesis and neovascularization, so as I mentioned to you before. In patients with diabetes and other chronic diseases, it improves wound healing and fibroblast proliferation and nerve regeneration. If we combine SVF with fat grafting in my daily practice, it just it decreases the fat volume loss after fat grafting procedure. When we transplant SVF into a radiation damaged tissue, we saw an increased tissue perfusion after healing, after the healing of the damaged skin. In most therapeutic studies at the SVF injection site, we saw an initial reduction of inflammation. When we apply SVF to a specific disease models, it also tends to reduce inflammatory cytokines and growth factors. And its regenerative potential is because of the result of cytokine release after injecting it. So, why we bother all of the preparation period? So why we just injecting the lipoaspirate to patients? So why we are doing this process? I think I was thinking the same process also before I met with the stem cells. So the end product of SVF is not a naturally occurring substance in adipose tissue. We are creating the SVF. SVF is not already present in adipose tissue. And although these stem cells are present in adipose tissue, they are not co-located. They are dispersed from each other. The application of enzymes, which is collagenase, to these cells changes the behavior and nature of the cell and makes a little bit stress on the cells. And it provokes the formation of more specific kind of cells. So SVF is a thing that we produce. It's not naturally occurs on lipoaspirate. So this is how I do it. And where we can take fat, actually we can take fat from any region. So But before harvesting fat, we need to give some fluid just to prevent bleeding. I mostly use this formula. It is a client formula, but you can use your own formula just to prevent bleeding. I'm going to talk about my formula tomorrow in the hands-on training. And you can ask me tomorrow, by the way. You don't need to just write it down all. We have to inject the tumescent solution in order to prevent bleeding, because if we don't give any solution before we harvest fat, it's going to bleed a lot. So we have to wash the fat tissue a lot, and we're going to use available cells. We're going to lose a lot. How to choose the right cannula? So I use 3 types of cannulas. The one, let me see the laser. This is the cannula I'm using for harvesting fat, and this is, you see, it has much bigger holes on it. And this is the one when I'm injecting the tumescent solution. This is much more thinner. This is 2 millimeter, this is 3 millimeter. And this is how I do the whole process. I'm taking the fat tumescent solution, as you see, into the syringe, and I'm injecting the area. I'm using the umbilical region to harvest, to make my incision, because it will be hidden after some time. You can see, and you can do it under local anesthesia. The patient don't have to take anesthesia. See, I'm harvesting the fat, and patient is comfortable, she's fine. Now we are going to the lab. You're gonna see this process tomorrow. I don't want to bore you too much for technical details. Also processing, it lasts for 30 or 40 minutes. And after the last step, you see SVF is ready right now for injecting for the patient. I'm using SVF for this patient for skin rejuvenation, for making her much more beautiful. This is another patient. You can harvest fat from anywhere. This patient doesn't have enough fat, so I have to use her backside. If you're gonna use extremities for harvesting fat, don't forget you better take it from both sides, for both arms, both legs, and both thighs. So it will be much more cosmetically good. You see, it's the same process. I'm harvesting fat from both sides. First, I do derma roller to the patient, because I have to open some pores before I injecting the SVF. All of is combination therapy. You need to combine stem cells with something else. You need to open some pores in order to just facilitate healing. Yeah, it hurts a little bit to the face, to injecting one into face, by the way, but it doesn't hurt when I'm harvesting fat. And bone marrow mesenchymal stem cells. You can harvest bone marrow mesenchymal stem cells from anterior superior iliac spine, posterior superior iliac spine, or tibia. And posterior superior iliac spine is the easiest one. If you're a new learner, if you're gonna do first time posterior superior iliac spine, I strongly recommend you to do that. And I'm gonna show you a case. This is how I do it. First, I'm injecting local anesthesia to the patient. Make a little bit push, and it can easily just go into the bone. When you feel you're into the bone, just inject the cannula. See, turn it. When you're harvesting the bone marrow mesenchymal stem cell, just take a little bit and turn a little bit more, and you can able to just take stem cell from every level of bone. So this kit just makes me to use every level of bone when I'm doing it. And you can easily take out the cannula. And this patient is suffering from a burn scar, and you see the scar is really red. First I did laser, CO2 laser, and then I inject stem cells. I'm gonna show you the result of this patient later in my presentation. And exosomes, I'm not going into too deep because Dr. Ellen already talked a lot about them, and there are more than 25,000 scientific studies going on about exosomes so far. And it's a new trend, it's gaining much more popularity. And I'm going to tell you when they first found in 1986 by Abraham and Johnstone, and they just found it in red blood cells of sheep, and they call it exosomes. What is their function? They transfer DNA, RNA, and proteins to other cells, and they alter the function of targeted cells. They have three types. We have animal-derived exosomes, and we have plant-derived exosomes, and we have engineered exosomes. So all exosomes is not the same. The one we are using in our daily practice, the one we are using in treating patients is engineered exosomes. They are exosomes of mesenchymal stem cells. They are exosomes of umbilical cord. So this is not a only exosome thing. So we engineer them to use them. Animal types of exosomes, I'm not going to too deep. Plant-derived exosomes, we can extract them from the plant's juice, leaves, stems, roots, seeds, and dried plant materials. They also contain DNA, RNA, and mRNA. And where do we use plant-derived exosomes, by the way, in our daily practice? And there are some studies about it. And adipose-derived stem cells treated with different concentration of plant exosomes from beet, lemon, radish, tomato, and wheat increase cell proliferation of adipose-derived stem cells. So they can able to increase our potential for adipose-derived stem cells also. We can able to use them in our daily practice, maybe in the future a lot. And they can able to just have some positive effects on chondrogenic differentiation also. And there are lots of creams about contains plant exosomes, by the way. And this is the exosome type we use in our daily practice. They are surface engineered. They contain some genetic and biological manipulation and chemical modification. And they are good to use. I love them, so I must use them. So maybe in the future, exosomes just be the first kind of therapy. They can able to just replace mesenchymal stem cell based therapies in the future. So the popularity is still growing. Maybe we only gonna use them in the future. And I'm gonna show you some of my case photos right now. And plastic surgery and regenerative medicine and shares the same principle. We use the patient's own tissue to restore and enhance the body. And for soft tissue and augmentation, the most commonly method is used for fat grafting in plastic surgery. So there is a variable rate of persistence after fat graft applications. And it's difficult to keep the fat graft permanence at an optimum level. But with the help of SVF, because it contains some of growth factors, and they are increasing the neovascularization, and we can able to increase graft permanence, and we can able to decrease the side effects of fibrosis and cyst formation after this application. We call it cell-assisted lipotransfer. I do this procedure a lot in my clinic. I usually combine fat grafting with stem cells in order to increase graft permanence. And this is a case. This is a 72-year-old lady. I only did SVF and fat grafting to her. It's not a surgery, think like that. This is only 1 month later, the procedure. This is another patient, 74-year-old woman, and I did SVF, fat grafting, and also did blepharoplasty to her upper eyelid surgery. This is 6 months later. This is after 2 applications. This is another patient. I did SVF, fat grafting, and also I did chin filler before I took the picture, and also did blepharoplasty to her. This is 5 weeks later. This is another patient, as you see. It's 1 month after. I did just 1 injection, fat grafting and stem cells. This is another patient. I know the photo is not so clear, but you can see in the right, this is after. You can able to see the skin is much more brighter, and there are much less dots on the skin. So the skin is much more brighter. This is 38-year-old woman, and she had a burn scar when she was a child, when she was 6 years old. And there is a really big burn scar on her left thigh. So what I did, because she doesn't love her thighs, she thinks they are a little bit prominent. So I harvest the fat from her both thighs, and I also harvest fat from this area, and I injected it below the scar. The scar was a little bit depressed also, and I also did CO2 laser, and I also did SVF application in the same session. So this is right after the procedure, but it's better because I'm still talking with her, and it's still better. And she sent me some of her photos, but they are not so clear. I didn't put here, but she's really happy right now. But she's gonna come to another session, by the way. This is not a therapy that you achieve the results only 1 session. And we can use stem cells for aging, skin rejuvenation also. Aging comes with decreased production of collagen. So with the help of adipose-derived stem cells, because they release some cytokines and growth factors, and they can able to improve fibroblast proliferation. So in animal studies, we saw increased dermal thickness when we inject adipose-derived stem cells to the animal dermis. We saw increased dermal thickness and collagen density in old mice. And we saw reduction in wrinkles caused by ultraviolet radiation. And this is the mechanism of happening, and these factors, I'm not going into too deep about the biochemical properties of it. And this is the interleukin 10, vascular enteric growth factor, prostaglandin A2, and hepatic growth factors upregulates the want regulation, and this one is down-regulating it. Also, we can able to use stem cells on acne treatment, but you have to combine stem cells with something else. And this patient, I did CO2 laser application and stem cells. This is 2 months later. If you want to see the full healing potential, you have to damage a skin with dermapen, you have to damage the skin with CO2 laser, because it's not going to heal itself when you just directly inject it to the skin. This is 2 months later. And this is 3 months later, CO2 laser and stem cell application. I did 2 sessions. And you can able to use them on vitiligo and hypopigmented scar too, but you have to combine them with phototherapy. So this is before and after. And also we combine it with phototherapy. So you need to combine them with something else in order to see the full healing potential. And this is 31 years old woman. You see the skin is much more brighter. Here's before, here's after. This is only stem cell application, nothing more. And this is much more a worse case. She was a cook before and she burned himself in the stove. So you see there is a devastating injury. So this is not only a stem cell procedure. We did a lot of surgery to her. And this is 2.5 years later. And we did lots of surgeries. We did epidermal skin spray, we did SVF, exosome injections, we did lots of surgical procedures, skin grafts, Z-plasties. That is what we can achieve after 2.5 years. And this is another patient. And you see, he is a casualty from a war. He was 4 years old, and you see his neck is contracted. He cannot able to just move his head upwards. And we also did multiple surgeries to him, by the way. We did, this is 4 years later, we did eyebrow implant, SVF injections, multiple Z-plasties, CO2 laser, and physiotherapy, and also eye implant, because he lost her left eye. This is a process. This is another patient after chickenpox infection, so I injected only one session. It's not a perfect result, but she is much more happier after the injection. Also, we can use stem cells on wound healing too. So wound healing is a coordinated process involving complex interactions between cells, growth factors, extracellular matrix. So it has 4 stages. Adipose-derived stem cells and bone marrow mesenchymal stem cells have critical importance for wound healing because they release some growth factors and cytokines, and they increase macrophage migration and granulation tissue. They cause increase in vascularization. And this is what they do. The wound healing has a 4 stage, and injecting stem cells makes the first 3 stage much more shorter period. So this is the original one. If we inject stem cells, it makes this 3 phase much more shorter. That means you can able to just heal the wound much more quicker. As I mentioned before, they have really good angiogenic properties, and we can use them on limb ischemia. And when we applied stem cells into ischemic limbs, we saw new collateral vessel formations after 6 months. I'm going to show you the X-rays about them. And this means we can able to use them on burger and diabetic foot patients, because you know there's no cure for burger and diabetic foot patients. And when we inject them to these patients, we really see a much more improvement in pain scores and walking distances. Also, you know, there is a term called pathologic wound healing, which we called keloid, which we called hypertrophic scar. And also, stem cells are really good at dealing with this kind of problems too. The scar formation is associated with inflammatory process in wound healing. And because they have some anti-inflammatory immune suppressive effects, they improve wound color and elasticity, as I did the injection to the burn patient before. And I'm going to show you some results about it. This is 20 years old male patient which was suffering from acid burn. And this is a 3rd-degree burn patient. And we also did some surgeries to patient. We also did some skin grafts. But you can see after 3.5 years later, she is looking much more than before, much more better. This is 37 years old male. And I did bone marrow mesenchymal stem cells to him. And he is a patient suffering from burn scar. You can see he's not able to just move his fingers and hands. This is only after 1 session. You can see her wounds are closed, and he can able to just move his hands much more freely right now. Only after 1 session. So this is 1 month later. And this is a filler complication. One of my colleagues sent me this patient. In a clinic, he had done nasolabial filler, And I think they got into angular artery, and he has a necrosis. And what I did, firstly, I just mechanically just take the excess tissue. I did the dermabrasion, mechanical dermabrasion. And after that, I applied CO2 laser. Right after that, my colleague is now harvesting the fat, as you see. I inject a little bit fat as fat grafting purposes because the scar was a little bit depressed. And after that, I inject stem cells to the dermal region in order to just prevent healing much more better. And we are doing the dressing right now. And this is him 1 month later. We're going to do a second session. He is much more better, but we're going to do a second session. This is another patient, 2 years old male. Third degree flame burn to the forehead. And as you can see, this is 1 year after. Of course, we did some surgery, but it's exosomes and mesenchymal stem cells just makes the healing potential much more faster. Also, we can use them on pressure sores also. This patient is not suitable for surgery, so I only inject mesenchymal stem cells to the wound. You see, after 6 weeks, the wound is much more smaller. It's the after. And also you can use them in diabetic foot and ischemic limbs. And this is before and after. Of course, you have to clean the wound, by the way. If the wound has necrotic tissue, if the wound has infection, there is no need to inject the stem cells to that tissue. The wound has to be clean. You have to take care of the wound, and you have to inject the stem cells in the same session. And this is another patient, 66 years old male. And 7 weeks later, you can see he has an atonic wound, and it's much more smaller right now. This is an X-ray of a patient that we did stem cell injection for increasing angiogenesis. And you can see this is 3 months after the injection. You can see much more vessels are formed after the stem cell application. So this is another patient. Gonna tell, this is 3 weeks later. You can see wound is much more cleaner, of course, much more smaller. Of course, we can able to close these wounds easily, but some patients are not suitable for surgery. So we have to use our maximum potential in order to just heal them. This is another patient. You see, this is 4 weeks later. And this is another patient. You see there's increased vascularization after injecting stem cell. And this is how I do them for ischemic limb. So I usually mark more than 40 areas in the trace of arteries of the leg. So posterior tibial artery and anterior tibial artery. I mark lots of areas on the arteries. And I did the injections to intramuscularly. And there's no point of giving stem cells intravenously, intra-arterial, so it doesn't affect the result, by the way. You have to do intramuscularly. This is how I do. I just push the skin and go into the muscle and inject it. This is another patient. He has a pressure sore, as you see, and the ischial region. So I did a surgery before, but it opened again because it's a hard region to close. And after it opened, I used stem cells again, and it closed itself, as you see. And of course, we can able to use them on hair regeneration also. Okay. And I'm going to show you some patients. This is before and after. Okay. Of course, it's not a hair transplant, but it really affects the result. And this is before and after. This is mesenchymal stem cells. And you can see it's much more better, but it's not a hair transplant. before and after. This is before and after. See, this case is really good, by the way. This is only just after one injection. Every patient has a different potential. Every patient just reacts to exosomes, reacts to mesenchymal stem cells differently. Some patients are really, you see a really good results. And some patients, you see good results. And this is me. I also did for myself, and it hurts a lot. And I'm going to show you a case, okay? This is a conjoined twin case I've been attended to. This is an interesting case because that's why I want to show you people. And first we put a balloon, we put an expander on them, and then we just fill the expander, and we make a 3D printing. This is an all crew job. I not only did this surgery myself, we have a big crew. And we separated them. They were two cute childs, and I think they're really good now. I didn't see them for more than 1.5 years. And this is the crew behind all the scenes. This is all the surgeons are dealing with just separating these two twins, and this is me, as you can see. And to close up, as plastic surgeons, we can able to use single autologous source for just in order to regenerate people, in order to regenerate tissues in the future, I hope. And maybe in the future, this is heart muscle, by the way, as you can see, and they created on lab. Maybe we can able to produce our own organs in laboratory. So there's a future on that I've been waiting for. And this is our team, and this is our bigger team. And muchas gracias.
Bueno, impresionante la presentación del doctor Melih. Estamos un poquito pasados de tiempos, así que solamente vamos a hacer 2 preguntas y después mañana lo van a tener todo el día los que hacen el hands-on para seguir preguntándole también al doc porque tiene mucha información. 2 preguntitas para él. Doctor.
I don't have too much experience just on keloid scars, but I used them on hypertrophic scars, and I saw a really good potential, but not keloids. So you can able to see keloid patients a lot in this modern world. So, but on hypertrophic scars, they're really good. So, but you have to combine them with laser. Okay, you have to combine them with something else. You need to just to see the perfect healing potential.
Okay. Otra pregunta. Sí.
Hello, doctor. Thank you for your cases. It's really nice to see all that medicine going on. I saw you use, maybe, I'm not sure, you didn't mention it, the Kotaro Yoshimura's cell-assisted lipotransfer. Is that correct?
Cell-assisted lipotransfer, yeah.
Have you seen any difference of applying the cell-assisted lipotransfer, as in thickness-wise? Is this thickness?
Thickness.
Is that a problem when applying cell-assisted lipotransfer?
What kind of thickness are you talking about?
The thickness, as in, Kotaro Yoshimura mentions that whenever it's too thick, more than 2 centimeters thick, then it does not regenerate properly and it reabsorbs. So basically the stem cells, so the SBF helps to angiogenize.
Improve angiogenic properties,
yeah. The zone, but it's only 2 centimeters in thickness.
What is the thing about 2 centimeters? I didn't get it. So the thickness.
So do you apply a lot more than 2 centimeters?
It's not about 2 centimeters. It's about, you just think about it's a core. The middle of the core doesn't have oxygen too much. So it's a graft. So if you inject it to a patient, the middle zone is the most susceptible zone to necrosis. So if you mix the fat, I'm going to mix the fat tissue with SVF in the syringe. I'm just mix them. So everybody has enough SVF when I inject the fat. So that's what is working. So I didn't see any negative effects after I started to use them with the SVF. And while I'm doing cell-assisted lipotransfer, I started to inject more than the original one, because if you know cell lipotransfer, you have to overfill the patient in order to see the best results. And now I'm doing just filling as much as I can. So it's better for me.
Gracias al doctor Melih. Mañana va a estar él también en la parte de la porción práctica. Pueden estar, los que van a estar van a poder disfrutar del doctor también y de todos sus casos. Bueno.